Study Unit 2.3 Functional Capacity of the Cardiovascular System. At the end of the study unit, you should be able to compare cardiac output during rest and maximal exercise for an endurance-trained and sedentary person. Discuss two physiological mechanisms that influence exercise stroke volume. Contrast the components of cardiac output during rest and maximal exercise for sedentary and endurance-trained individuals. Discuss the contribution of cardiac output during rest and maximal exercise for sedentary and endurance-trained individuals. Outline the dynamics and proposed mechanisms for cardiovascular drift. Outline cardiac output distribution to major tissues during rest and intense aerobic exercise. Describe the relationship between maximal cardiac output and VO2 max amongst individuals who vary in aerobic fitness. Indicate factors that contribute to expanding arteriovenous difference during graded exercise. Contrast cardiovascular and metabolic dynamics during upper body versus lower body graded exercise. The functional capacity of the cardiovascular system is mainly determined by cardiac output. Thus, we will first talk about cardiac output. Cardiac output is the amount of blood pumped by the heart during a 1-minute period. Again, maximal cardiac output represents the functional capacity of the cardiovascular system. Cardiac output is the product of heart rate times stroke volume. How are cardiac output measured? There are 3 methods to determine cardiac output: direct FIC, indicator dilution method, carbon dioxide rebreathing method. For the sake of this subject, we will only have to name the 3 methods. If you want a more broad explanation of each of them, you can look at your textbook. Cardiac output during rest. Cardiac output varies during rest by various factors such as emotional condition. Every minute the left ventricle pumps 5 liters blood for a 70 kg adult male, 4 liters of blood for a 65 kilogram adult woman. These gender differences are due to a woman's average smaller body size. How do endurance training influence cardiac output during rest? Very, very important. Remember, cardiac output is the product of stroke volume and heart rate. Endurance athletes have a higher stroke volume. This high stroke volume can be attributed to an increased blood volume, myocardial contractility, and compliance of the left ventricle. The lower heart rate can be attributed to an increased parasympathetic tone and a reduced sympathetic drive, which lowers the heart rate. Very important. This increased stroke volume is the main cause of endurance athletes' high cardiac output during exercise. This leads us to what happens during exercise in cardiac output. As exercise intensity increases, systemic blood flow increases as well. Thus, cardiac output increases progressively with exercise. When blood flow plateaus, it means blood flow is meeting the metabolic demands of the tissues. Remember, very important, endurance athletes reach very high maximal cardiac output by mainly a bigger or larger stroke volume. Let's look systematically at the cardiac output of trained and untrained persons during rest and during exercise. Trained and untrained persons have the same cardiac output at rest, as both need the same amount of blood flow to meet the metabolic demands during rest. But remember, trained people have a higher stroke volume, thus they do not require a high heart rate to obtain the same cardiac output. Untrained individuals have a higher heart rate at rest when compared to untrained individuals. But note what happens during exercise. Trained athletes have a fantastic cardiac output of 35 liters per minute. This high cardiac output is due to the high stroke volume, as you can see. Exercise heart rate is the same for both trained and untrained individuals. Therefore, again, the high cardiac output of trained athletes is mainly due to the increase in stroke volume and not heart rate. Stroke volume can also be used in a clinical setting. For example, people with valve dysfunction will have a low stroke volume, as well as people with heart failure. Maximum heart rate of conditioned individuals is the same as sedentary people. The difference in cardiac output, and therefore actually also VO2 max, is mainly due to maximal stroke volume. How do one improve stroke volume? We will look at two factors, diastolic filling and systolic emptying. How does stroke volume increase during exercise? There are three mechanisms. Improve diastolic filling. Remember, during diastole, the heart relaxes. This relaxation increases cardiac filling. There's more blood in the heart, which means more blood can be pumped by the heart. This is the Frank-Starling mechanism. A little more about this mechanism later. A larger systolic emptying. Neurohormonal means the nervous system combined with hormones. The neurohormonal effects increase the forceful ejection of blood from the heart and causes an increased stroke volume during systole. Remember, systole means when the heart contracts. And lastly, an increased blood volume and reduced resistance to blood flow due to exercise adaptations. Do you remember this from Exercise Physiology 1, the tension-length relationship of the sarcomere? There is a specific sarcomere length where maximal tension is developed as there is maximal actin-myosin interaction. The decrease in actin-myosin interaction produces less cross-bridge interaction and causes lower tension. This also applies to the heart. You do not want a stiff or non-compliant heart. One also does not want a stretched out heart, for example. This is heart failure. Very, very important. The Frank-Starling mechanism. The Frank-Starling mechanism is defined as within physiological limits, the force of heart contraction will be directly proportional to the initial length of the muscle fiber. Let's think back on the tension-length relationship. An increase in end-diastolic volume, venous return, and a decreased heart rate stretch these myocardial fibers and causes a powerful stroke volume during contraction. Thus, an increased preload, meaning diastolic filling, causes an improved systolic emptying or an improved stroke volume. Improved diastolic filling occurs during swimming because of the body's horizontal position that promotes venous return. Other sports that is upright causes gravitation to impede blood flow and hence cardiac output as well. Improve systolic emptying, the second mechanism to improve stroke volume. Systolic ejection occurs due to exercise-induced elevation of systolic blood pressure, or afterload. There will always be residual blood volume. Not all blood is pumped out of the heart. Catecholamines, epinephrine and norepinephrine, or adrenaline or noradrenaline, released during exercise and increase the contractile force of the myocardium and hence also the stroke volume. Stroke volume is determined by the end diastolic volume. This is the volume of blood that stays behind after diastole, subtracted by the end systolic volume, the amount of blood that stays behind in the heart after systole. This is the amount of blood that is pumped by the heart each beat, or stroke volume. Let's apply the previous mentioned to a condition called cardiovascular drift, a condition that are characterized by a reduced stroke volume and an increased heart rate during prolonged exercise, especially in warm weather. What causes this condition, cardiovascular drift? When one exercises for a long period, even if it is submaximally, water loss will occur through sweat. An increase in temperature also causes a redistribution of blood to the skin for cooling down by means of evaporation. Collectively, these cause a decrease in plasma volume and hence a decrease in plasma volume and venous return. According to the Frank-Starling mechanism, a decreased venous return will reduce stroke volume. Due to the decrease in stroke volume, heart rate should increase to maintain a constant cardiac output. This increase in heart rate cannot compensate for this low stroke volume, and hence cardiac output also decreases. Again, cardiovascular drift is characterized by a reduction in cardiac output and stroke volume, while heart rate increases during long, steady-pace exercise, especially during high ambient temperatures. How does blood flow, aka cardiac output, distribute in the body during exercise? Blood flow to specific tissues is always in proportion to the metabolic demands of that particular tissue. In the schematic, you can see how blood flow distributes to different tissues during rest and during exercise. Note how much blood is distributed to the muscle, especially when exercising. Environmental stress, level of fatigue, and exercise type and intensity affect local blood flow, but most of the cardiac output is diverted to the active muscles during exercise. When we apply the principle of specificity, we can see the greatest amount of blood is diverted to the aerobic slow contractile muscles, or the oxidative muscles, at the expense of the more anaerobic fast contractile muscles, or glycolytic muscles. Two factors cause blood flow to be diverted to active muscle: hormonal vascular regulation and local metabolic conditions in the muscle self that causes vasodilation or vasoconstriction. During the redistribution of blood flow with exercise, there is a reduction of blood flow to the internal organs, the visceral organs, such as the kidneys, the skin, except in warm conditions, and the liver. Increased oxygen extraction from the blood maintain the oxygen needs of these tissues. Obviously, blood flow to the brain and heart can't decline. We see this with exercise. Coronary blood flow increases 4 to 5 times during exercise. Coronary blood flow is the blood flow to the heart. Cerebral blood flow or blood flow to your brain increases during exercise by about 25 to 30% when compared to resting blood flow. Cardiac output and oxygen transport. There must always be a reserve of oxygen during rest. There are about 1 liters of oxygen available to the body at rest. The resting oxygen consumption is only about 250 to 300 milliliters per minute. Thus, there is a 750 milliliters of oxygen excess that are not used and are transported back to the heart. When you start quickly with exercise, this 750 milliliters can be used when metabolism increases dramatically at the beginning of exercise. During exercise, the increase in maximal cardiac output is extremely important because it increases the person's VO2 max, or the capacity to circulate oxygen. On this figure, we can see a strong correlation between maximal cardiac output and maximal oxygen consumption. If somebody has a low oxygen consumption, they will also have a low cardiac output, and vice versa. On this figure, we can see that sedentary people have a low maximal oxygen uptake, and hence a low cardiac output, while conditioned athletes have a high oxygen uptake and cardiac output as well. How does cardiac output differ in men, women, and children? Women have a lower maximal cardiac output when compared to men, as men have higher hemoglobin concentrations. Children also have a lower cardiac output when compared to adults because of an increased heart rate in children, which leads to a reduction in stroke volume. Oxygen extraction, the arteriovenous oxygen difference. Exercise oxygen consumption is increased by 2 mechanisms: an increased cardiac output, increased total quantity of blood pumped by the heart, and an increased arteriovenous oxygen difference, increased use of oxygen carried by the blood. This means the ability of the body to transport and also use oxygen. Oxygen consumption, VO2, is determined by the product of cardiac output times arteriovenous oxygen difference. This figure illustrates the progressive expansion of arteriovenous oxygen difference from rest to maximal exercise. The green line represents the oxygen levels in the arteries. The purple line represents the oxygen levels in venous blood. Note how oxygen content difference gets larger as one trains more intensively. Thus, the more intense the exercise, the more oxygen is withdrawn from the blood. The factors that increase the arteriovenous oxygen difference is an increase of cardiac output to active muscles, an increased muscle microcirculation, an increased capillary to muscle fiber ratio, an increased size and number of mitochondria, an increase in aerobic enzymes. All these factors contribute to an improved oxygen transportation throughout the body. The cardiovascular adaptations to upper body exercise. An arm exercise causes a higher oxygen consumption when compared to leg exercise. This can be attributed to the relatively smaller muscle mass activated in arm exercise. Other factors that also causes a larger submaximal oxygen consumption in arm exercise when compared to leg exercise include a lower mechanical efficiency of upper body exercise. Also, recruitment of additional muscles to stabilize the body during arm exercise, like the core muscles, for example. Upper body exercise is more difficult when compared to lower body exercise as it leads to an increased heart rate, an increased pulmonary ventilation, an increased rate of perceived exertion, and an increased blood pressure. The increased heart rate during upper body exercise when compared to lower body exercise can be attributed to increased feedback stimulation from the brain's central command to the medullary control center or the cardiovascular control system, increased feedback stimulation to the medulla from peripheral receptors in active tissue as well. In summary, the standard submaximal exercise load, power output or oxygen consumption for upper body exercises causes greater metabolic and physiological strains when compared to lower body exercises. If you struggle with this study unit, you are always welcome to make an appointment with me so I can explain it a bit broader, in a broader sense. The end.